So I'm going to demonstrate iliopsoas.
Boof, 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 boof. I think she's a bit nervous. Boof, boof, boof.
Right.
Okay, good. There is the pulse that I'm feeling under my fingers. It's sometimes quite difficult to feel because sometimes it's quite light. It's also sometimes difficult to feel because it's sometimes tricky to find the right anatomical area.
Guys, I'm just going to leave the video to run, and I'm going to just go to the loo quickly. And so you guys just watch the video and listen to my explanation, and I'll be back in 2 minutes. Okay.
So what you do is if you can feel the start of the groin muscles, and then you come up.
Sir, the video is not audible.
That's it, and down. And now you can palpate it up, and I can feel the psoas major contracting under my fingers. All right, so relax now for me. One more. No. One. There's the pulse under my fingers. So this is wide enough for me to avoid the neurovascular bundle. And from that point there, boom, there, I'm in the psoas muscle.
And how do I know it?
And
Because I
that
can
change in
feel the resistance.
corresponded directly to her little squeal, her ouchie. Okay, which is good correlation with where my needle should be. So that is just a demonstration.
Right, the next one I want to show you guys is the subscapularis.
The 15 will probably go up to a 60 or a 75. So we've got to feel the chest wall.
So this is the lateral
And
approach.
Outer border of the scapula.
And this is
There's
a
the outer border
difficult
of the
patient
scapula there, and
because he's
there.
quite flabby.
So that there is the
So you
space
can't see
between
much.
the chest wall there
You have to
and
palpate
the
and feel.
vein. And our angle of our needle is going down like that because the chest is curved.
And the angle of the needle is very
down
specific.
and through. You can also imagine, you guys can see that there is like a convex shape between the chest and the axilla. And at the bottom of that convexity, our needle is going to go in. We go like that. It's approximately 45 degrees, but it's down the line of my sight.
So we're outside the ribs, inside the
So
ventral
that
surface of
50
the scap,
has possibly just gone into it.
into the
I
muscle.
feel I need to go with a longer needle.
That needle's too short for that size of patient.
I'll go in just above. Straight in like that. There we go. Now we're certainly into the muscle. We got a nice response from Fahad as well. There we go. The last 15
Okay,
mils,
and that is,
I can
so that is subscapularis. The last needle I want to show you is, last video is the deep calf. So we're looking for deep posterior calf. There we go.
Like that. There we go. So she's in full side lying, right? Like that.
Right, so we do
So our superficial or our surface anatomy is
flexor
shin
digitorum
bone,
and tibialis
which is
posterior.
there. That's the deep compartment like that. That's probably the level of the intermuscular septum between the deep compartment and the superficial compartment. So our needle needs to go behind the shin bone straight down like that. Not anterior because you'll hit the bone, not posteriorly because you'll go into the neurovascular bundle. So the type of conditions that you're going to be needling like this for are medial shin soreness, medial compartment issues, tibialis posterior tendonitis where you want to needle the muscle, shin splints, tibial shin stress fractures, and shin reactions. Now she's got an area just over there of increased tension. There it's nice and soft. Then it gets a little bit tense over there, and then it softens up over there again. So I'm going to needle it just over there. There's the bone. There. So just inside the bone, needle goes straight down. I'm going through flexor, the common flexor muscle. I need to just angle a little bit back because I hit the tibia. I need to slide behind the tibia. There we go. Into tibialis posterior. Okay, so that's a full 50 mils.
So the needle is vertical down, behind the tibia, in front of the neurovascular bundle, Going through flexor, digitorum longus, and into tibialis posterior.
You must take cognizance of the size of the calf on your bed. So if you've got a very, very thin calf, that would belong to, where is she? Your partner. She's not here. 60 with interosseous membrane. Okay, I'll do that once more. And I've got to slide my needle just behind the tibia, going vertical down to stay in front of the neurovascular bundle, just like that. And she can feel it.
Now we flip the
Because now we're going to do the same leg, but from
leg on the other side. And we're going to do flexor hallucis longus now.
the evertus, peroneals. Palpate the muscle behind. And remember that flexor hallucis longus in the upper half of the leg lies behind the fibula. And as it goes down the leg, it tracks medially to come out behind the medial malleolus. If I go straight in there, I'm going to hit the bone at about 25 mils. There, I'm on the bone. So I can't get to, there's the bone. So I come out, I can angle my needle backwards, and I slide behind the fibula into the FHL muscle, or I take my needle out, shift it across a little bit by 5 mils, and I go straight down again. Behind the fibula, straight down into the FHL muscle. You saw in the diagram that the soleus muscle comes all the way around to the side here, and at the level of the fibula, it has the intermuscular septum with the lateral.
Okay. Right, guys. Any questions? Any comments? Dara, go ahead.
Sir, so at a time, how many attempts can we make in order to locate the muscle properly when we are new to this technique and using it? So at a time, how many times can we puncture in order to find the muscle?
How many times can you needle the muscle to find the pain?
Yeah. So if we are facing any problem to locate the muscle initially, how many times, how many attempts can we make at a time to locate that muscle? How many times can we puncture the area?
Oh, no, as many as you need to.
Is there any, there are no contraindications to that?
No, not really. No, I mean, you should know more or less where your patient's pain is coming from. The area of the muscle, because you palpating the muscle and you can feel the hardness of the muscle and you can reproduce the patient's pain. Then it's just a matter of getting the needle into that same spot. That's the difficult part, is the accuracy of using the needle to hit that trigger point, to hit that band. It's not very easy. There's a technique to learn to feel where the spasm is. Imagine where it is on your finger and imagine the needle going in the same direction and going in. So sometimes it takes 3 or 4 times to get it into the right spot.
And
Next
sir,
question.
I have one more question.
No.
So sir, is it normal to expect soreness in the muscle the next day, the one that we have needled on the current day? Is it normal to expect that muscle to be sore?
You can expect soreness. So there can be soreness. The needling causes micro trauma, micro bruising. So sometimes the patient will be much better depending on how you needle them, and sometimes they will be quite bruised, and they will be quite bruised if they're very acute and you needle them quite aggressively, or you don't needle them softly, or if you needle them very aggressively and you cause a lot of bruising. And remember, everyone reacts differently. You know, some people are bleeders. Some people bleed very, very easily. And if you don't know that about them, you're going to cause a lot of big hematoma, a lot of bleeding in their quad. And then other things is people have a different perception of pain. So Dara, you might be someone who's very squealy. And if you have a pain, oh, it's the worst thing in the world. Oh, my physio really hurt me because they made me sore. But me, I might be an athlete who enjoys pain, because as far as I'm concerned, if I'm in pain, I'm training hard, I'm playing hard, my body's been put through its paces, I want pain. So it's a different perception. Okay, so you have to try and evaluate your patients. You must know where they are in the pain cycle, or in the acute, subacute, chronic phase, and you must needle accordingly. And you must also needle in accordance with how they tolerate pain or how they perceive pain, especially if you're seeing them for the first time.
Sir, the another question that is arising in my mind is, so if the soreness is there the next day and yet the symptoms have not yet settled, how long can we wait to needle that area again?
The needling soreness can take 24 to 48 hours to subside. Now, if you needle without needling soreness, the pain is likely to go away quite quickly.
Okay.
But if your needling is aggressive and it causes soreness, or if the patient's a bleeding reactor, then it can take 24 to 48 hours for that soreness to settle down. Unless if you cause them a hematoma, it'll take longer. They will be walking with a limp. Yeah. Okay. So it's always good to rather needle less aggressively than more aggressively to start with. Yeah.
Understood. Thank you, sir.
Pleasure. There's this question here from Kanchana. Hold on a second. Kanchana, how many sessions are required for trigger point to release completely? Well, Kanchana, we don't know exactly how many sessions, but normally about 2 to 3 to 4 sessions is what it takes. But it depends on the operator, it depends on the physio, it depends on the needling technique, depends on the patient, how often you see them. It depends on how acute or how chronic, how long the pain has been around for. So your patient might need 8 to 10 sessions, or your patient might need only 2 sessions. Okay.
I understood.
Yeah, 1+.
Can we use ice pack over needled muscle in order to reduce the soreness?
Okay, so what did I say in the beginning of the lecture about icing? Can someone answer that question?
If it is an acute pain, we can use the ice. If chronic, we can use the heat.
Yeah, so actually other way around, because if it's acute pain, lots of spasm, you're going to needle softly, gently, and put a hot pack on to promote blood flow, because the spasm is making the blood flow, is preventing the blood flow. If it's chronic, long term, and you want a lot of micro bruising to promote blood flow, you might needle them and cause microtrauma muscle soreness, and then you might want them to ice to prevent the soreness of the treatment, because you have created the blood flow. You just don't want the soreness. Okay.
Thank you, sir.
Next question. Yes, you can use, there's a question here about the electromodalities. Yes, you can do electro needling. You can use your needles as your pads, and you can connect up the needles to your e-stim or to your TENS machine, and you can electrostimulate them via that. It's called electro needling. Yeah.
Sir, one more question.
Sure.
Can we activate a muscle after needle? Can we give post isometric exercises to a muscle which?
Yeah, you can. Yes, you can, but you must be very cautious, because remember, if you're needling and the microtrauma is causing trauma, you don't want to go and overload that muscle with resistance exercises after needling, because you could cause a strain to the muscle, or you might damage it or make it worse. So rather depending on the type of needling that you do, rather get them to wait a day or so before they go back to training, especially heavy resistance training or especially acceleration speed training. Okay. Right, there's a question on the chat here. If a patient with a forearm fracture post-surgery has severe stiffness, can we dry needle them if flexion is restricted? Well, it depends on what the restriction is. If the restriction is in the joint, you need to mobilize the joint. If the restriction is in the muscle, then yes, you can needle the muscle and see if that will help. And needle both the muscles on both sides. Yeah. All right, guys. I think that's been a pretty good session. It's been pretty long. How long do you wait until after inserting a needle? What do you mean, Shweta? How long do you wait after inserting? How long do you leave the needle in?
Yes,
Is that
sir.
your question?
How long do you put the needle in?
The needle goes in for about 2 to 3 to 4 to 5 minutes. Depends on how long it takes to make a cup of tea. Only kidding. It depends. Also the patient, you know, you might want to needle your patient with short needle times if they are anxious. I have a patient at the moment. She doesn't like needling. She doesn't like it. I literally have to say to her, sit down. Let's put the needle in. I try and I do a few things. She's so, okay, fine. Right. That's it. It's in the right place. I'm going to leave it now for 3 minutes. Oh, why so long? Why so long? Okay, 2 minutes. And I come back and distract her, take it out, put it back in. But, you know, there's some patients who just, their reactions is such that you just can't do a lot of needling or you can't do it in the way that you want to. You just have to work around that. But there's no absolute set time. It varies from patient to patient. What neurological conditions should avoid needling except epilepsy? Well, your patients must be conscious, obviously. You're not going to needle the unconscious patient. The patients that do best to needling are the ones with increased tone, increased spasticity. But the improvements that we notice are not long-term. So the improvements are short-term. But you can needle your neurological patients. You can needle your multiple sclerosis. You can needle your post-stroke patients. You can't needle infants. You can't needle kids unless they have authorization from their parents or their guardians. Depending on what the age of consent in your country is, if it's 16, then you have to wait until a teenager is 16 until they say that they can be needled, or 18, depending on that age. Yeah. Okay, guys. Yes.
Is needle beneficial for neurological spasticity in CP? Can we reduce spasticity of CP using needles?
CP, you know, CP is a bit more trickier. CP is a central overload. CP is an overriding factor from the cerebral cortex. It depends. I think if it's a mild form, you may have a lot more success than the severe forms. But I don't have a lot of experience. I really don't have a lot of experience within the neurological sector because I haven't worked in the neurological sector.
Okay, thank you, sir.
How long can we needle in the same point? Can we do back-to-back days if the condition does not improve? I don't like needling every day. You must give at least 1 or 2 days in between the needling to see whether the needling is working. And also if you're causing bruising, it's like if you're going to do some myofascial release, are you going to do that on a daily basis and just end up treating over the bruise that you caused from the day before? So I like to give at least 2 or 3 days in between treatment sessions. Do we have to follow anatomical lines or fascial lines as we do in other soft tissue research? No, not necessarily, but you can do if you want to. You absolutely can. You know, if you're working on a particular line, on a particular spiral line or the frontal line, then you can needle along those lines and you can needle the different muscles along those lines to release any tension in that specific line or to activate that line or that chain. Is there a better outcome if we tape the needled muscle? Certainly. Yeah. After you've needled, you can apply some tape, absolutely, and then take the tape off at the next session. Is there any state where needling is the best choice of treatment line in the specific sports condition? I don't know. I'm not sure. You know, you always have to, as a clinician and as a professional, you have to be open to what the diagnosis is and what is best going to treat the patient. You know, if we just do the same thing over and over and over again, half our patients will get better and half our patients won't. You have to be treating in accordance with the diagnosis and in accordance with what's best to treat a facet joint syndrome, what's best to treat shin splints, what's best for the patient. You have to do all this within the understanding of where the patient is at and what they're doing. If the patient is training for a marathon and they've got 2 weeks to go and they've got a chronic muscle tear, they're going to keep training. You've got to provide support to them. So you can't go and do cross frictions that's going to bruise them so much that they can't train. You've got to go and do something that's going to reduce their pain or help them, but at the same time, they're going to be able to train. Yeah.
Any more questions from anybody?
I think we're done, Saurav. I think that's good.
Yes, sir. Extremely brilliant session as always, and I give a lot of thanks to you that you joined at time and then patiently you answered all the questions raised by them, cleared all the doubts. But yes, as we know, this is just a first leg to start with, and I am thankful to CEO Manjit Sharma sir, and I'm thankful to Diwakar sir, Kalimullah sir, that who thought to bring this innovative program so that we can actually have interaction, theoretical interaction through the online, and then we can actually meet for the practical purpose so that we can devote more and more timing. I actually am very, very thankful to all you participants, and I'm a bit sorry for those who were asking me, sir, can I join? And they could not join even at last moment. But yes, still the gates are open, they can join, but they may not have the kind of interaction you had because sir is very busy, but still definitely will be meetup in the practical classes. I'm very, very thankful to all of you for joining today, and most of you are working, but still taking your time out and giving yourself the best. So, sir, anything you have to say?
Yes, guys, thanks very much. Thanks to my Rehab Academy, who have been working with us for the last 18 months to, number one, organize, facilitate, and bring face-to-face courses to India from last year, but unfortunately that was not possible. And then last year we did some online courses with them. We did some refresher courses. We did some online theory courses, some introductory courses. And now this year we are working full steam ahead to come to India in May. So a lot of you have been in touch with me for a long time. I know some of your names. I see some of the familiar names here. Thank you so much for sticking with us. Thank you for your flexibility, for your understanding when we had to change the dates from early in the year and even from last year as well. It's very unpredictable. Hopefully everything is going to be fine from a travel sense for me to come to India. I have a multi-entry tourist visa for the next 5 years. So if the Indians will let me in with that visa, I'll be there. If I need to have a business visa, I will get the business visa. But God willing, and Corona free in terms of travel and in terms of your cities, the courses happen. Thank you very much.
Sure, sir. I'm sure that most of the participants would be getting vaccinated when they will be joining our program, and traveling and our conduction of the program will be quite easier. So thank you so much, all participants. Thank you so much, sir.
Very much.
Thank
you, everyone. Thank you, Saurav. Thank you, Manjit.
And everyone in the group can discuss and keep your questions. So whenever we meet up, sir will be taking up that question. You can discuss in the group according to your whatever the practice you do and however the question you get it from the studies and everything. Thank you so much, everyone. Thank you, sir.
And then if you're amongst you've got some questions on the group, keep them for the face-to-face courses, and then we'll answer them, demonstrate, chat about, tutor, all of, and don't forget, we've got the dry needling practitioner certification exam to do on the course as well. So prepare hard, study your anatomy. That's the most important thing. Go through all the risk factors, but absolutely from a safety point of view, make sure you know exactly where to identify the different pulses, the nerves. try and practice how to palpate the ribs, and we'll see you in there. Okay.
Please share the necessary documents or the material so that we can prepare.
Yeah, the materials, yes, the materials will be sent to you. They won't be sent to you right now, but they are sent to you ahead of the course. So a couple of weeks before the course, once we are 100% going ahead with the course, the material will be sent to you in electronic format. 100%.
Okay, thank you, sir.
Okay, thanks everyone. Thanks guys. I'm gonna go. All the best.
Thank you so much.
Saurav. Thank you,
Thank you.
Samanja.
Thank you.
Take care. Enjoy your weekend. Thank you.
Thank you. I would request you, sir, to end the meeting. Thank you everyone for joining today. As I know it's working day for all of you, but